In the next 20 minutes, what I'm going to do is to update you about how we're going to optimize antiretroviral therapies. This is my disclosure. I think we all know that the current guidelines really based on a number of big clinical trials to support early treating everyone regardless of CD4 cell counts. This is based on the START trial. You can see that up to 60% serious events and death reduction. Timpano trial, about 40% reduction of death and severe illnesses. And the HPTN 052 have shown clearly that it's close to 100% reduction in transmission to the discordant partner. And this is based on, you have heard a lot about the life expectancy after have been treated with ART. And this is one of the Asian, I would say, that may be the first Asian's data based on our Thai national AIDS programs with the sample size greater than 250,000 in the database. And you can see that if you treat start ART in individuals at 20 years old, and the data, this is after survival beyond 6 months of treatment. You can see that in blue is mean at least the CD4 count at least 350, and you can see the life expectancy can be add up at the end to about 80 years old. So it's clearly that starting antiretroviral therapy is lead to a normal life expectancy, including the Asian data. Now, what is the most recent guidelines telling us which regimen we should prefer to go for as a first line? Basically, you pick one of the NUCs in this blue. It can be TAF, can be tenofovir or abacavir, but abacavir needs to be in a fixed dose single tablet regimen and combined with one of the cytidine analogs and either one of the integrase inhibitors, including the most recently approved by the US FDA, Bictegravir. So if you look at the US guidelines, mainly only one class to go for is the integrase inhibitor. How about the less advanced, less recent guideline in Europe that recommend more than one class? So either integrase inhibitors, boosted PI, in this case it boosted darunavir or ripivirine. But in reality, most of the resort-limited guidelines, WHO, South African guidelines, and Thai guidelines, we still have to go with efavirenz. It's a main first-line regimen, and ripivirine may be another option. So NNATI base is really the main option to go for. You have heard nicely in the last couple of days in this conference that ending AIDS is if we have to achieve, and the first thing is we have to reduce the new infection and try to early diagnose cases and put them on treatment and make sure that we be able to manage poor adherence issue and try to avoid drug resistance problem. So the way to do that is we need a real good treatment coverage and prevention coverage. Two, the problem of treatment is a couple of things. One is the cost, and you see that in reality, most countries cannot afford integrase inhibitors, and we're also facing with the issue of long-term toxicity. So optimization is the need because if you want to accelerate the access to treatment, you need more simple, safer, and affordable treatment option. The way to optimize treatment, I would summarize in these three approaches, and based on a number of clinical trial study. The first thing you may do is to optimize triple therapy, or to optimize the dose, or optimize double drug or dual drug therapy. And the number of studies focus either in the treatment-naive populations or treatment-experienced populations. Now, the first optimization is dolutegravir, because it's very likely that, it's not likely, it's clearly that there's a strategy put together with the global network to be a single tablet regimen, make it cheap. And this is the recent effort that to make generic TLD, tenofovir, lamivudine, and dolutegravir as a low cost in 90 countries. It's only cost $75 a year. But they still need a number of issues to address before really, put into the public health policy. So the global networks or partnership put together a network they call Optimize. So they come together and try to address a number of questions. The first thing is to look at three major populations: the pregnancy population, HIV, TB co-infected populations, and also the adolescent children populations. Just recently, I think we have heard nightly about the discussion yesterday about the concern of some of the data from Botswana about the potential risk of neural tubes birth defects. And just a few months later on, and also come another observational study, which is bigger sample size and analysis, and showing that with the up to about 1,700 dolutegravir treated versus a prevalence about 4,600 study in this observational study have shown that there's a similarity or a similar rate of the neural tubes defects, about 10-11%. So there's no difference, but again, this is an observational study. There's another prospective study recently presented at COI this year, looking at the comparison between dolutegravir versus efavirenz in late pregnancy. Here the results showing that dolutegravir appear to be well tolerated and effective compared to efavirenz, and the PK findings have shown that dosing of dolutegravir 15 milligrams once a day appear to be appropriate in this population. Another trial, Dolphin 2, this is an open-label, multi-center randomized controlled trial with the sample size about 250. The data expect to be come out roughly about in September 2020. How about this regimen, dolutegravir triple therapy in tuberculosis? This is a phase 3B study, inspiring. Basically, randomized TB patient that taking 4-drug regimen with rifampicin, and then for 2 months, and then rifampicin INH for another 4 months. So the patient randomized into taking into dolutegravir doubling the dose of 50 milligram BID plus 2 NUCs versus efavirenz. And then after the complete of 24 weeks, then switch to a standard dose of dolutegravir. And here is the 24 weeks interim analysis data. You can see that there's a non-inferiority result at this observation. So this is a conclusion of dolutegravir 50 milligram twice daily appear to be effective and well tolerated in TB co-infected adults receiving rifampicin-based TB therapy. And in this study, there's no, the iris observation rate is very low. The other big trial that we should keep an eye on is the ADVANCE study. This is going to be a big sample size study. It's 1,100 cases, and the enrollment try to be mimics the real setting in the clinical practice. So starting age from at least 12 years old, and randomized into 3 arms. So dolutegravir either with TAF FTC or tenofovir FTC compared with the efavirenz-based regimen. So this is a non-inferiority randomized control study. The primary endpoint will be at 48 weeks. So expecting the result by early next year. Now I'm going to move on to the dose optimization. We have been involving in 3 studies, efavirenz, lopinavir, and atazanavir. We're going to present only efavirenz and atazanavir dose optimization study. In terms of efavirenz study, you can see that we have done at HIV-NAT have done a PK, a number of ARV comparative study. In this case, if you look at efavirenz, the data here is the historical control from the Caucasian's published paper, and you can see that AUC exposure is 2.2 of efavirenz when you use the standard dose of 600 milligrams QOD. In the Asian population, mainly in Thai population, you can see that with standard dose of 600, the exposure is much higher. And when we dose the Thai population, the Asian population with 400, you have a very comparable drug exposure of 2.1. And interestingly, if we go back decades, a few decades ago, the first trial efavirenz phase 2, you can see that 200 milligrams, even 200 milligrams, 400 milligrams, is doing pretty good compared to 600 milligrams. So that's why the Kirby Institute, led by Mark Boyd and also David Cooper, have initiated this study a few years ago called the Encore-1 study, comparing 400 milligram efavirenz versus a 600 milligram standard dose in the naive population adult. And you can see that this is the sample size about 300 individuals, and in orange is a standard dose, 600 milligrams, and the blue is a 400. And you can see that at the actually the primary endpoint is the cutoff of viral load at 200. But I show you here is the 50 copy cutoff. You can see that it's also non-inferiority among the 2 arms. But interestingly, in terms of tolerability, in terms of adverse events, and you can see that there's a significant higher side effects among higher dose compared to the lower dose. And the durability data up to 96 weeks has been confirmed as well. Interestingly, again, at 96 weeks result, you see that the 28% of the standard arm have to stop treatment because of equivalence as a dose of 600 compared to the 400, which is about 2-4 higher. In terms of the CSF level of equivalent, whether it is sufficient in the lower dose, the study confirmed that both 400 and 600 can achieve adequate level in the CSF in terms of HIV replication inhibition. This is just, again, it's not a good idea to compare different studies, but it just gives you a impression that here, this is the integrase inhibitor, here's the NNRTI, and this is a lower dose equivalent. This is the Lepurian. So the efficacy of once daily NNRTI is still is an impressive outcome in terms of efficacy. And when so the issue is that whether we can have a single tablet of 400 milligram, the answer is yes. So the US FDA tentatively get the approval for this single tablet regimen of 400 last year. The issue is that for in pregnant women and the tuberculosis with rifampicin, we definitely, by current data, need to go for 600 milligram single tablet. What about the atazanavir? The atazanavir in the Asian population, again, you see that compared to historical control of 300 milligram, is a higher exposure, about 40% higher exposure. And so we have done a non-inferiority trial comparing, we call the LASA study, comparing the standard dose of atazanavir versus the 200 milligrams lower dose atazanavir in non-inferiority randomized control designs. And this is the result. So you see that the lower dose at 200 of atazanavir achieve a higher percentage of patients with viral load below 50 copy compared to the standard arm. And this is due to the higher percent of discontinuation of patients with clinical jaundice in the standard dose of atazanavir. So in Thailand, so we moved from the PK to efficacy trial and to the guideline implementation. And that have led us to saving the cost of the atazanavir treatment in the second line. Keep in mind, this is the Wales biological suppressed population. Now I move to the last part of the 2DR, the dolutegravir-based dual treatment. I think we have heard a lot yesterday and also some of the evening session with VIF that this is a trial from ACTG 5353 in a naive population to confirm the PADO study. You see that with the sample size 120 at 24 weeks, regardless of baseline viral load above 100,000 copy or below 100,000 copy, you can see that it's about 90% undetectable rate. And the Gemini's 1 and 2, VIF has recently, 2 weeks ago, has announced the results of 48 weeks endpoints with the sample size together of 2 studies is for 1,400 adults. And you can see that this is has met primary endpoint of non-inferiority. But again, we have to wait for the detail. They're going to present it at the Amsterdam meeting. How about the switching from viral suppressed population? This is another double regimen of dolutegravir with lepurian, and again, reaching non-inferiority comparing to the baseline ART versus the switch to the two-drug regimen. So these two-drug regimen, dolutegravir and rilpivirine, in a single tablet regimen has been approved by the US FDA the end of last year. But keep in mind, this is not the naive population. It's a biological suppressed population for at least 6 months and no history of treatment failure, no resistant history data to dolutegravir or rilpivirine. You look at we haven't seen the new guideline from WHO coming out yet, but I think based on the last year position of WHO, it's interesting to see that how we're going to transition from efavirenz 600 to 400 or dolutegravir 50 milligrams. So the discussion is really have to look at two things. One is the baseline pre-treatment NNRTI HIV resistant percentage. If below 10 and low-cost dolutegravir regimen is not available, so 400 efavirenz single tablet should be a good choice. And if you have a higher rate of drug resistance as a baseline, so it's better to go with dolutegravir regimen. So in summary, I would say that now you have a number of data of optimized first-line treatment. There's pros and cons consideration. So these two is the triple dolutegravir-based regimen, and the dual dolutegravir-based regimen is the dolutegravir 3TC. So I think the concern right now, until we have more data, is the early pregnant women. We have to be careful, and basically we better switch to others. With TB taking rifampicin, we need to double the dose of dolutegravir. The rest is fine. In the dual dolutegravir with 3TC, in hepatitis B co-infection, because you have only 3TC only, it's not a good idea to go with these dual regimens. And you look at the efavirenz 400, I think in general it's pretty good, except with rifampicin you have switched to the single tablet with efavirenz 600. Rilpivirine is not good at all for people taking rifampicin. For treatment experienced individuals, we have a lot of data based on decades of data based on the NNRTI-based failure. So the recent data on downing is you can go with the 2 NUCs with dolutegravir, which is a very good, it's superior to lopinavir boosted regimen. However, for dolutegravir-based failure, we don't have any data, and in the clinical trial, it needs to be based on the rational approach. If you're facing patient with no drug resistance detection at all, maybe you should try either switch or try to improve adherence. If drug resistance detected, which is very, very, very rare, you might go to boosted PI or NNRTI with boosted PI. So to end my talk, I'd like to thank a number of all the study participants in LASA and OnCall study, and all my co-workers at HIV-NAT and Thai Red Cross as research center and all the funding agency. Thank you very much for your attention.
The issue of low dosing of protease inhibitors, I remember a long time ago the group from Liverpool looked at the correlation between body weight and drug levels. Mm-hmm. And I was impressed that for protease inhibitor it was very tight. I remember they did for Kaletra, for every 10 kilos a patient weighed more, the drug levels were 10% less.
Yep.
And as someone who's very heavy, I was always concerned that, for me and for others.
Right. Right.
So I'm always thinking, when we do these studies of lower doses, do we consider that for patients who have very high BMIs, was that considered, thought of?
Yeah, I think that's a good point. So that's why I should emphasize that this is the Asian population. And among our study population, because we don't have a market difference of a BMI, so I cannot claim that this should be generalized for a non-Asian population.
So we'll have time for discussion in the end. So, Kiat,
Yeah,
thank you
you
very much.
Thank you very much.